Good morning, good afternoon, and good evening, everyone. And welcome to the Scientist.com Inside Scientific and Indivumed Services webinar titled Longitudinal Plasma Samples, Paving the Way for Precision Oncology. I'm Liam Sanyo from the events team here at Scientist.com, and I'll be your host today. We're very fortunate to be joined by Dr. Mirka Allerding and Anna-Sophie Skoof, who will present a cell-free plasma biobank and describe the role of longitudinal plasma samples for cancer research, disease monitoring, and biomarker development. And with that, I'd like to welcome the first speaker, Dr. Mirka Allerding. Mirka, thanks so much for joining us today, and the floor is yours whenever you're ready.
Hello, everyone. Thanks for joining us today, and thank you, Liam, for the kind introduction. As stated in the announcement, my colleague Anna and I will use this presentation to introduce Indivumed Services longitudinal plasma collection. We will list advantages and benefits of longitudinal plasma for cancer research, and finally explore applications for biomarker research and development of companion diagnostics. I will start with a short introduction. While solid biopsies are the gold standard for molecular evaluation of solid tumors, liquid biopsies have the potential to gain influence in clinical routine due to their complementary features. Where tissue samples offer information on the tumor makeup at the time of extraction, their significance is limited when it comes to revealing the extensive intratumoral and intertumoral heterogeneity, as well as the future evolution of the tumor. In addition, obtaining tissue biopsies can cause discomfort to the patient and hold clinical risks, such as potential surgical complications and an increased risk of seeding the tumor to other sites. Moreover, it is not certain that solid biopsies will yield enough tissue for the respective planned analysis. For these reasons, serial tissue biopsies are often impractical. However, a liquid biopsy has the advantage of being a minimal invasive method that can be repeated for multiple times over a long period, thus enabling the clinician to monitor the life development of the tumor and its molecular markers, as well as the impact of treatment on the patient. This close and timely evaluation of a patient's individual treatment response has the potential to greatly influence personalized cancer patient management. The most common form of liquid biopsy is the blood draw, but other liquids, such as cerebrospinal fluid and saliva, are also in use. Both forms of biopsy give access to tumor DNA for analytical purposes. While solid biopsies offer tumor DNA from cells that directly come from the cancer tissue, blood draws focus on circulating tumor DNA in the donor blood. In 1948, cell-free DNA, or cfDNA, was first described in human blood. It derives from healthy tissue and immune cells that naturally release DNA into the bloodstream. The process by which cfDNA enters the bloodstream is not fully understood, but its typical size of about 170 base pairs correlates with DNA wrapped around a nucleosome and suggests that cfDNA is mainly released by apoptosis and other regulated cell death and clearance mechanisms. A subset of cfDNA is cell-free tumor DNA, in short, ctDNA, that derives from tumor cells. A differentiation between CF and ctDNA can only be made through a detection of tumor-specific markers and mutations after DNA extraction from the blood. Still, the presence of identical cancer-relevant mutations in both DNA from the tumor tissue and ctDNA from the blood of the same patient show the high potential of liquid biopsies to characterize or even detect unknown cancer growth anywhere in the body through a simple blood draw. While circulating tumor cells, CTCs, extracellular vesicles, proteins, miRNA, and mRNA can also be found in liquid biopsies and used for cancer research. Currently, ctDNA is the main focus of clinical tumor analysis. Indivumed Services started the collection of oncological whole blood samples in 2016 from meanwhile 46 clinical sites all over Germany. The blood is shipped to our lab in Hamburg, where it is processed to cell-free plasma within about 72 hours. Over the last 7 years, we've grown a pool of more than 27,000 patient samples. We are focused on the collection of multiple blood draws for each patient over the course of one or more therapies. To complete the product, we receive more than 30 clinical data points from our collaborating medical practices and clinics, accompanied by the complete patient consent for targeted genome analysis. The basic requirement of our cell-free plasma biobank is the highest possible plasma quality. While tumor tissue quality and usefulness in research is dictated by a low ischemia time as well as optimal fixation time, cell-free DNA quality in plasma depends on optimal cell and DNA stabilization. A low genomic DNA contamination and low CT-CF ratio maximizes the relative ctDNA content of a sample, which is needed for reliable assay detection. These criteria are dependent on a standardized collection and shipping workflow, as well as an optimized extraction and storage process. In general, ctDNA accounts for only 0.1 to 10% of total cfDNA. But levels of CF and ctDNA are highly dependent on many factors, such as cancer properties. For example, cancer type, cancer localization, size, or stage. The treatment types, surgery, chemo, or radiotherapy, or other non-cancer related conditions like renal failure. As already said, a differentiation between CF and ctDNA can also be made through the detection of tumor-specific biomarkers. The detection of these markers depends on a low cfDNA to ctDNA ratio to avoid false positive and false negative results in later analysis. Unfortunately, wrong sample handling can lead to an additional increase in cfDNA due to a white blood cell lysis and the release of genomic DNA into the sample. This increase of cfDNA by about 70 to 90% makes the detection of ctDNA even more difficult. Luckily, quality controls can show whether high cfDNA levels in the sample reflect the situation in the patient's blood, or if a contamination of artificial released genomic DNA with a greater molecular weight has taken place. To guarantee the best plasma quality, we checked for both the amount of cfDNA and the gDNA to cfDNA ratio in samples from CRC patients under different collection and processing conditions. In the figure, you can see qPCR results for the cfDNA yield of 1 milliliter of plasma using either EDTA or Streck tubes for blood collection and a single or double spun centrifugation protocol. In the right figure, you can see qPCR results showing the ratio of normal apoptotic cfDNA fragments, represented by a 41 base pair amplicon, to gDNA fragments with a bigger 305 base pair amplicon. FF and FFPE DNA were used as respective positive and negative controls for gDNA. As you can see, both the cfDNA yield as well as the CF to ctDNA ratio show the best results when using Streck tubes and a double-spun centrifugation protocol. In addition to these analyses, we run quality controls every year to check whether prolonged storage of the cell-free plasma at -80 degrees Celsius has any effect on the cfDNA in the sample. So far, no changes could be observed, and a constant quality can be guaranteed. Based on these results, we've chosen to collect all our samples using the Streck cell-free DNA blood collection tubes. We could confidently show that their stabilization agent allows for a consistent plasma quality when collecting and shipping blood from all over Germany, while at the same time rendering it unnecessary to freeze the blood, but instead allow for storage at room temperature until processing. In addition, with the double-spun processing protocol, to remove cell debris from the plasma, we can guarantee state-of-the-art plasma quality for every vial kept at -80 degrees Celsius for long-time storage. One of the great advantages of liquid biopsies is their ready and constant availability, as well as repeatability. In contrast to a single blood draw, longitudinal plasma sets consist of multiple blood draws from the same patient over time. Our set starts with a T0 blood draw, which is taken before the initiation of each new drug therapy. It is followed by up to 5 additional blood draws during treatment at intervals of 4 to 12 weeks. While the number of blood draws can vary based on treatment duration and patient response, the collection of 2 10 milliliter Streck tubes per blood draw enables us to extract an average of 6 milliliter cell-free plasma per time point. A full sample set of up to 6 time points and corresponding comprehensive data can be used to monitor the live response of both patient and tumor to the treatment. By covering even multiple treatment lines, the clinical reality of patient blood samples is accurately reflected. My colleague Anna will now elaborate on the aspects and benefits that longitudinal liquid biopsy collection offers, as well as the big picture that comprehensive data points make possible.
Yeah, thank you, Mirka. We will start with have a closer look to the information, so the clinical data you will receive with our samples. They are divided into 3 different kinds because they're either connected to the patient, to the therapy, or to the time point, these informations. And we have general patient information, for example, age or gender of the patients, and then other information about the disease or tumors classification, including the type of cancer, the stage, information about the morphology, and also about the classification of these tumors. And additionally, also if there's metastasis and what kind are those. Then we have therapy information or treatment information. What was the intention of the therapy? Which therapy line the patient is on, and also information about the type of treatment, so which drugs he receives, and also the doses information for these drugs. Then we have 2 different response information. First is the clinical response. This is not based on imaging techniques, but is focused on the performance of the patient. So how is the patient feeling during treatment, and what is the therapy outcome of the patient. This is also including the Karnofsky score and information if the therapy ended according to plan or if it was cancelled, the reason for the therapy end. And you will receive a clinical status per time point and also one for the therapy end. The other response information is the tumor response. This one is based on imaging techniques like MRT or ultrasound, and you get information about is the tumor, is there a remission, a complete or partly one, if there's a progression or a stable disease. To better characterize the samples, we also included biomarkers information from this 21 biomarkers you can see on the right side of the screen. We received their information if they are mutated or not mutated either, or if they are positive for these biomarkers or negative, and then sometimes also if there's a weak or strong positivity here. Further data is available upon request, so we could go back to the clinics in our network and collect additional data point if they are available. For example, their possibilities are the method of the detection of the biomarkers or radiology data concerning the tumor size information, for example. All in all, we have around 32 to 45 data points if they are available. Of course, we have here clinical reality sampling, so not every patient gets every test and so on. So we get information that is there. What is currently in our biobank, so our inventory, we have around 27,000 patients. Mirka mentioned this before, and around 700,000 plasma aliquots in total. Because it's a higher number, because we are storing around 2 to 12 million aliquots per time point, so per collection, and also multiple therapy per patient. So we have a lot more aliquots than patients in our data bank, and around 3,000 patients per year will be added to our data bank. The most common entities are quite good matching with the frequent tumor sites here in Germany. So on the most samples, we have breast cancer samples with our 27.5% of our samples, followed by CRC with 15.1%, and then also under the top 10 are lung cancer, pancreas, lymphoma, stomach, ovary, leukemia, multiple myeloma, and prostate cancers. But it's not limited to these cancer types. We have a variety of others as well. Regarding the therapy intention, we have most of them, 67% are palliative, receive palliative treatment, followed by adjuvant, neoadjuvant, and curative. So currently with our clinics, we have a bit of a bias towards late stage patient with palliative treatment. The therapy distribution is most of them receive chemotherapy, but also a high percentage gets monoclonal antibodies or then a combination of chemotherapy and targeted ones. But we are sampling all kind of systemic therapy really. So we have no exclusions there. Next, we are coming to the analysis, so what you can do with samples and where they're used for in the clinics. As Mirka mentioned before, there are several targets in the human blood, but the ctDNA really showed to be the promising biomarker to use in clinical settings. Several attributes of ctDNA can be quantitatively analyzed, for example, tumor-specific alterations, genetic or even epigenetic ones, mutations of oncogenes, tumor suppressors, mitochondrial DNA, and also analysis of copy numbers, variations, allele frequency, or hypomethylation of gene promoters are possible. In the last years, a lot of assays for ctDNA testing has been developed. Most widely used are the PCR tests. There are different kinds like quantitative PCR, digital PCR, or droplet PCR. And there are several also aspects like beaming digital PCR that allows higher sensitivity than the normal PCRs. All in all, they're really sensitive, fast, and inexpensive, so really good to use in the clinic. And there's the possibility of single locus, but also multiplexed analysis, and also point mutation analysis is possible with them, but they are only for a limited number of known molecular alterations. So within the last years, more and more the next generation sequencing approaches enters, as they are highly sensitive and also really high throughput capable, and you get a lot more data out of them than from the PCRs. They allow known and unknown multiple molecular alterations analysis, and also targeted sequencing and chromosomal copy number changes, but they are more expensive than PCRs. Tests that are already approved by the FDA as a PCR test is, for example, the COVERS EGFR mutation test V2 by Roche. It was one of the early tests approved in 2016 already. It's approved for lung cancer and looks for mutations on the EGFR. And for the next generation sequencing is the Guardant's 360 CDx, which detects biomarkers and is approved for lung and breast cancers, for example. Not really used in clinic till now is the whole genome sequencing approaches, where they are non-targeted next generation sequencing technology, which know a whole genomic profile of the tumor DNA, but they really require high concentration of ctDNA and are really pricey and have a high turnover time due to the high data you receive, and also then the bioinformatic analysis that had to be done afterwards. Okay, then now we have a look at where we can use this test in the clinical reality. So in times of targeted therapy, the detection of druggable molecular alterations and the choice of the respective tailored treatment can really improve patient outcome, as well as the early detection of cancer. So now for detection and for the diagnosis and biomarker evaluation, the gold standard is still the tissue biopsy, but the use of liquid biopsies had spread in the management of patients and really improved the standard clinical care. They are mostly used as a companion diagnostic tool, so combined with other diagnostic tests. ctDNA levels correlate with tumor burden, stage, vascularity, cellular turnover, therapy response, and relapse in a wide varieties of cancer, and is therefore really useful to target those questions. It has a short half-life, only from around 16 minutes to 2.5 hours in the blood, so it allows a real-time snapshot of the tumor. With tumor growth, ctDNA levels rise, which allows detection when it gets over the ctDNA detection limits. So therefore, an early stage detection in cancer screening is possible before diagnostic tools like imaging tools would be able to identify these cancers. But this early detection assays had a few challenges to overcome. So the low percentage of ctDNA, Mirka already mentioned, makes a high sensitivity of the tests warranted, but this always comes with high costs. And also there are many different genomic aberrations to target. I showed you before, so there must be really a good examination which one are the best. Next to high sensitivity, there's also the need for high specificity, because you want to avoid a lot of false positive results for cancer screening, because this is always accompanied with fear for the patients. When the start of treatment, ctDNA levels should drop if the treatment is effective. So this allows a real-time monitoring of the treatment response. This is really important to avoid ineffective treatment and unnecessary side effects. And you want also to early detect resistances against the therapy, to avoid also the unnecessary treatment and to change to an effective treatment then. In the end, you want to detect molecular remission for the patient if the treatment is really effective here. But of course, there is always the risk for a relapse, and so even if the treatment is useful, so the therapy progressive and metastatic cancer can occur. So you want to detect early a molecular relapse and also the detection of minimal residual disease here. which is not really easy to do by imaging techniques. So studies showed that liquid biopsy could have here a real impact, as they detected these minimal residual diseases several weeks earlier compared to radiology. Also possible is that you use liquid biopsy samples for prognostic test to evaluate the risk for metastatic relapse in these patients, and also spatial and temporal tumor heterogeneity could be analyzed, and clonal evolution and progression monitoring is possible. So all in all, liquid biopsy testing is really useful during the whole disease, and because ctDNA levels and alterations are really something that evolves over the whole time of the disease. And I hope I could show you that in the last years, the research opened really new avenues for cancer diagnostic with important clinical opportunities for personalized medicine. And liquid biopsy has a great potential here for improving cancer treatment, but further studies are wanted to explore all of them, as till now, most of this in clinics is only used in metastatic cancers so far. Longitudinal plasma biobank samples really could help here, and I hope we managed to give you a quick overview over the use, advantages, and applications of liquid biopsies, and an insight in our longitudinal plasma collection. With this, I want to thank you for your attention and your time, and we are really happy to answer your questions.
All right. Well, thanks so much, Anna and Mirka, for the great presentations today. All right. Well, let's get started here. Kick things off with a great question. So you said that ctDNA, the amount in samples, is only about 0.1 to 10%. This person says that they'd imagine the isolation of cfDNA could be challenging. Do you have a recommended way or a kit for the isolation, and what concentration could be expected?
Yes, thank you for this question. In general, you can obviously use every kit, and we have had no complaints with our plasma so far. For the quality test, for example, we use the Maxwell RSC kit with the cfDNA extraction kit, and we had 5 to 30 nanograms per milliliter of cfDNA, and yeah, this worked for us.
Fantastic. All right, next one. How do you search for the sample sets, and which criteria can you take into account?
So yeah, basically we can search for everything that's indicated in our clinical data. So, but common things are a specific treatment or one substance also, or the histological type, but also the sample age is possible, and treatment history or the outcome. That's everything. It's like we can do really personalized searching here. And we also offer pre-data sets, so the customer to give the customer an impression of what the data looks like really, and what to expect from the samples here.
Excellent, thanks, Anna. All right, how do you ensure that the T0 samples are treatment naive?
Yeah, as we heard, there's a lot of importance for early stage, and like also that yeah, screening and detection, early detection assays development is here important. So that's an important question for that. We have a set of criteria we look at. So does this patient had any additional cancers to which he already has received treatment, for example? Was there a surgery before? Then he's not really naive anymore. And also we look at the date of the diagnosis, and then when is the blood draw really, and how long is the time between that. So a short time patient difference there should be like that the patient should be naive here, or there's a good chance that he is or she is. Yes.
Perfect. Yeah, great answer. What do you is the maximum and minimum amount of plasma that I can buy? Is there a minimum and maximum?
So we aliquot our samples or our plasma in 1 milliliter aliquots, and therefore you can buy from 1 milliliter to up to 12, but it depends on availability. But this is the range you can get.
Fantastic. All right, next question. How do you differentiate between healthy and tumor cfDNA?
To differentiate between healthy and tumor cfDNA, you would use a kit that is specifically designed for this, because the only difference is actually the mutation on the DNA. And yeah, using a kit, you would specifically look for a mutation and thus know whether there's ctDNA in the sample.
Excellent. And can ctDNA be isolated from frozen total blood samples?
I guess it would be difficult because of the freezing process. The DNA would be a little bit damaged. So this is not the optimal sample you would choose.
And I think also the blood cells would be destroyed, and then we have a huge concentration of gDNA there, and then the detection would be more complicated. Yeah.
Excellent. I think that's just about it for questions, so we'll call it there. But Mirka and Anna, thanks so much for your insights today. It's really been a pleasure having you with us.
Thank you for having us.
Definitely our pleasure. Big thanks, of course, also to the audience here for participating, and of course, Indivumed Services for sponsoring this event. And in closing, we hope you enjoyed this Scientist.com, Inside Scientific, and Indivumed Services webinar, and we'll see you again next time. Have a great day, everyone.